Greetings to all. Welcome to another session of Physio TV. So today we'll be having Dr. Apurva Jadhav. Let me give you a short introduction about Dr. Apurva Jadhav. Dr. Apurva is currently working as an assistant professor in neurophysiotherapy department in Bharatiya Vidyapeeth College of Physiotherapy. We are more than happy to have you, ma'am. Now I would like to request Dr. Apurva to kindly start with the session.
Hello, Shivani. Thank you for the kind introduction. I would like to thank Sancheti Institute of Orthopaedics and Rehabilitation for this opportunity that they've given me to present a talk. I would also like to thank Sancheti College of Physiotherapy for this opportunity that they've given, the physiotherapy opportunity that they've given, where I can present this talk. So without wasting any time, I think we proceed to the topic that we're discussing today. So today, our topic for the seminar would be falls in elderly. As Shivani rightly introduced, I am currently serving as an assistant professor at Bharati Vidyapeeth School of Physiotherapy, Pune. Today we'll be talking about falls experienced by the elderly population. That is a population above 65 years of age. So the objectives of today's session would be that by the end of this session, the viewer should be able to explain what is fall as an event with its prevalence, enumerate the risk factors and associated comorbidities with falls, explain the various assessment tools available to assess fall with the psychometric properties, while give a brief about the fall prevention and management programs that are currently being practiced and are available in literature. So what we all know is that falls is defined as when a person comes to rest inadvertently on the ground or on the floor or any other lower surfaces. It can also be termed as a trip or a slip. What we also know is that substantially the elderly population is on constant rise. So is the associated medical problems that our geriatric individuals face are rising with an increase in the elderly population. One of these major health problems, as we rightly stated, is falls, with its prevalence being something around 28 to 35%. What we also understand is that this increasing prevalence of falls is also leading to a lot of injuries related to falls. And 3 out of every 10 individuals experiencing fall is also having death as one of their complication. These falls are completely preventable, and therefore such deaths can also be preventable. And here comes the role of a physical therapist, or in fact, should I state, a multidisciplinary approach to prevent such falls, which are causing a huge pocket on our economic, they're giving us a huge economic burden. Therefore, for such a high prevalence problem, there should be some good mechanism to handle such problem. So looking further into falls, we'll now see what are the risk factors associated with these falls. As we all know that fall will have both intrinsic and extrinsic risk factors. Intrinsic risk factors will be anything associated with the patient, the structurally or functionally with the patient. So any previous history or disease like PD or any hip or knee, the post replacement, or even other arthritis issues of the hip and knee, or any other vestibular disorders or neuromuscular disorders, such patients are on have higher risk of fall. A few medications have been associated with higher risk of falls. Visual impairments have been associated with higher risk of falls. Similarly, cardiovascular histories have been associated with higher risk of falls. Some extrinsic factors such as poor lighting, poor handling of the assistive aid, unfavorable flooring such as loose carpets, slippery floors, and any obstacles present over the floors are associated with a higher risk of falls. Similarly, when we take these extrinsic factors into consideration, there are also some situational factors where urgency at night to use the washroom is increasing the risk of fall. Urgency to attend a telephone call is increasing the risk of fall, so forth and so wise. So as we right now mentioned, there are various risk factors of fall. Amongst these, what literature suggests us is the highest falls are caused due to impairments of the intrinsic factors, where impairment of balance, impairment of gait, histories of vertigos, some respiratory or cardiovascular diseases are increasing the risk of fall. Tremors are increasing the risk of fall. Visual impairments, previous history of fall, and associated fear of fall that patients have are all increasing our risk of fall. Similarly, females are said to be on a higher risk of fall, and increasing age, of course, is one of the major risk factor associated with fall. And a few extrinsic factors, like we just mentioned, out of which slippery floor and the usage of stair have been found the most common factors which are responsible for fall. We have a few other associated factors like consumption of alcohol, low physical activity, which should be one of our considerations, which is increasing the likelihood of fall in our elderly population. So this enumerates all the risk factors that are necessary, that should be taken into consideration when we are assessing our patients with falls.
Sorry to interrupt you, Dr. Apurva.
Yes.
Can we have a zoom view of all the parameters so that our audience will be able to glance all the parameters?
Okay, I'll try. Yes. Can I just end the slideshow and zoom and show it to you all?
Yeah, sure.
I think there's an option of zoom in. Yeah, is this okay? Is this visible?
Yes, it is.
Yeah. Do you want me to repeat everything, this slide?
Ma'am, we can quickly go through it once if it's fine with you.
Yeah, sure. So, as I just mentioned, that there are some intrinsic and extrinsic factors which are responsible for fall, out of which literature suggests us that a few of the factors are highly causing falls, out of which one of them is poor balance and any gait abnormalities, history of vertigo, chronic respiratory diseases or respiratory ailments, any cardiovascular diseases, any CADs, coronary artery diseases, or cardiovascular, cerebrovascular diseases and cardiovascular diseases, history of tremors, visual impairments, a previous history of fall, and associated fear of fall is increasing a likelihood to fall. Similarly, you have females which are on higher risk of falls, and increasing age, which we all know that is causing us a lot of falls. Other than that, some extrinsic factors which have proven to cause a lot of falls is slippery floors and usage of stairs, difficulty in usage of stairs. Apart from that, I feel what literature suggests is alcohol consumption and low level of physical activity is increasing the geriatric population's likelihood of fall. So these are the risk factors that are supported by literature, which are increasing our elderly population's likelihood of falls and should be taken into consideration while we provide rehabilitation to such patients. Similarly, we have some comorbidities associated with falls. Comorbidities like individuals presenting with walking disability, previous walking disability, or vision impairment. Patients who have vision impairment, their likelihood of fall is increasing. Similarly, patients with any cognitive impairments presenting with cases like Alzheimer's, dementia, have increased likelihood of fall. Patients with type 2 DM, arthritis, have an increased likelihood of fall. Also, we would like to cover the complications associated with any such fall event that has occurred. So the first and foremost complication that might occur due to any fall is injury. Out of this complication of injury, fracture remains the most common injury that occurs in the geriatric population. So almost 10% of cases or patients who experience fall come to EMD with a case of fracture. Out of all of these, I think 2%, what literature suggests is 2% of these fractures involve fractures of the hip. And we all know that this hip fracture leads to long-term mortality, which is within a 1-year mortality, which rises up to 27%. Also, there are other associated injuries that can occur apart from fracture, like some soft tissue injury. There are cases of traumatic brain injury, head injuries, etc., etc. What falls also lead to is a lot of reduced mobility and loss of function, which further leads to muscle weakness, joint stiffness, and the cycle continues so forth. Falls also lead to a lot of dependency and psychological issues like depression, anxiety, and fear of fall. Patients will usually present with reduced quality of life and also have increased mortality. So this is what we've just discussed right now, that falls are associated with increased fear of falling, increased hospital stay, and trauma to the limbs. This in turn increases dependency, immobility, and your patients are more vulnerable to fall henceforth in the future. So recurrent fall history increases henceforth. Also, a previous fall in the last year with a patient coming with impairment in balance and gait will be our predictors for falling in henceforth in future. Also, what we need to understand is any fall that has occurred, the first followers, whom we would rightly call, first followers will usually present with a lot of fear of fall and associated depression due to loss of mobility. This symptom of associated depression can be treated by something called as selective serotonin reuptake inhibitors, which are drugs which increase the likelihood of fall. And therefore, if a patient of fall is coming to the OPD, we must likely also have a medication review in our assessment, where any disease causing or increasing the likelihood of fall should be noted, and if possible, changes or enhancement in the medication chart can be done. With the basic definition of fall, the risk factors, and the associated comorbidities with complications of fall, I think we would further move ahead to how would we assess any patient coming to us with fall. So what we primarily need to see is any patient presenting to the emergency department with fall. We need to assess a few things. We need to assess the injury. We need to assess if there were previous falls in the past 1 year. If the patient had lied on the ground and was able or unable to get up. If there was loss of consciousness associated with the fall, which we are suspecting syncope, if there was associated LOC. If any of this items is positive, we consider our patients on being of high risk of fall. In such patients of high risk of fall, we go for a multifactorial risk assessment. But basically, we'll assess all the risk factors that we have just discussed, and we'll give an individualized, tailored, structured program for such patients for whatever we've assessed. So whatever positive assessment findings have been there, we'll treat them accordingly. And such patients are kept a follow-up within 30 days time period. While if a similar patient coming to the emergency department who had any of this is not positive, like the injury, less than 2 falls in past 2 years, lying on the ground and unable to get up, and syncope, any of this one is, if it is not present, you immediately assess the patient's balance and gait. The most appropriate tools to assess this balance and gait should be considered the gait speed and or time up and go. If the gait speed is less than equal to 0.8, such patients should be considered on an intermittent risk of fall. Or if the time up and go scale scores our patients above 15 seconds, such patients are considered as an intermittent risk fallers. And for such patients, you will give a tailored exercise program, which will address their strength issues, their balance issues, their gait issues, and also a lot of education about fall prevention, because this is a moderate risk of fall and we do not want these patients to enter into the high risk category. If your patient has good speed and good time up and go score, which means your patient is on a very low risk of fall. And in such patients, you advise a lot of physical activity and also education, because we do not want these patients to enter into intermittent risk or high risk. Likewise, if during assessment, like during the entry point, if your case finding is an opportunistic case finding, like during history, a patient coming to you for some other primary issue, and during history, you all get to know that your patient has experienced a fall in the previous 1 year. In such patients, you ask a 3 key question, which judges their likelihood of falling. So you ask the patient if he has fallen in the past 1 year, if he feels unsteady while standing or walking, or if this problem of fall is really worrying to the patient. If any 2 of them come positive, you consider the patient as a low risk faller, and you further give the same protocol of educating your patient and giving physical activity as their exercise program. So this is your algorithm that everybody should follow when taking into consideration any geriatric individual coming to you with gait balance disturbances. And the primary tool of assessment should be gait speed and time up and go scale, and or time up and go scale. Here we will be seeing other associated outcome measures that can be taken when we will be seeing our patients with fall. So I think we all know this part, and we do assess our patients on this, but a detail about this. So we should assess a patient on tandem standing, 1 leg standing, the Berg balance scale, Trinity test, the mini best scale, the 4-meter walking test, the dual task test, the functional gait assessment, the time up and go test, the short physical performance battery. Muscle strength can be assessed with hand grip strength assessment. Fear of falling should be assessed with FES scale. Any issues with the vestibular system should be assessed via Colpix-Dix maneuver. Vision problems should be assessed with detailed history taking. Hearing problems should also be assessed with detailed history taking and an adequate referral to an ophthalmologist or an audiologist or an ENT wherever necessary. While ADLs can be assessed with scales like Barthel, etc., etc. Cognition can be assessed with scales like MoCA and other tests available. Delirium also needs to be assessed with confusion assessment methods and various tools available in literature. As I just mentioned, the 3Q questionnaire remains important in your geriatric patients, in your patients who complain with a history of fall. Dual tasking also is a very important scale. Geriatric depression scale remains an important scale to assess for any depressive disorder, while a patient with low nutritional status should be assessed with a malnutrition universal screening tool or a malnutrition screening tool. While the environment can be assessed with Westmead home safety assessment and or a fall behavior scale for the elderly person. Similarly, as we just mentioned, 2 of the most important outcome measures which predict falls very, very accurately is your gait speed and your time up and go. So gait speed and time up and go should be assessed in all our patients. And otherwise, as we all know, as I just mentioned earlier as well, that there are a few drugs which increase the patient's likelihood of fall. So a detailed drug history of the patient is required. and we need to rule out for any, they're called as FRIDs, that is fall risk increasing drugs. So we need to rule out for any presence of FRIDs in your patient. While a detailed cardiac history, noting the blood pressure while the patient is supine, and then standing to rule out for any orthostatic hypotension, or ECG if possible. Your multifactorial risk assessment should also include a detailed cardiovascular history. As we just mentioned, cognition can be measured with your MOCA scales, your mini mental scales, if possible. And the 3-report risk factor assessment tool, the 3 questions which we just asked for, remain important during the assessment. We also mentioned about FES being important and the elderly person's own perception about his or her fall. These remain all your various assessment tools available in literature. What we also need to note down is out of all these tools, none of them, except time up and go, all other tools, none of them are accurate predictors of fall. What they do assess is associated problems that may lead to fall, like balance. They might assess gait, they might assess something else. So these all tools are readily available in literature, readily available everywhere online, only to help us to assess balance or gait or anything else. But the primary tools which are good predictors for fall remain your time up and go scale and your gait speed. So our first scale remains the Trinity Performance Oriented Mobility Assessment, which is an excellent retest reliability and have very adequate correlations with tug and gait speed. You have a very important and good scale, that's your time up and go scale, which again has an excellent retest reliability and has good correlation with your work balance, gait speed, and Barthel index. You have your work balance scale, which again has an excellent inter-rater reliability, but has low sensitivity for predicting fallers. You have your dynamic gait index, which again has an excellent inter-rater reliability and correlates adequately with work balance, self-perception test, etc. Next you have is the minimal chair height standing ability test, which has a good sensitivity but is not very well versed with specificity. You have the Hendricks fall risk assessment model, which is similar like the minimal chair height standing ability. You have the 5 times sit to stand test, which has an adequate retest reliability and also correlates well with your tug and gait speed. You also have your FAB scale, which has an excellent retest reliability and has excellent correlation with your BBS. You have your mini best scale, which remains one of the most accurate tool for identifying older adults with a history of fall. This is still not predicting fall, but is identifying older adults with a previous history of fall, and it correlates very well with your original best scale and your work balance scale and your time up and go scale. And you have your steady, which again has a good sensitivity and good specificity. These are a few self-report measures available in literature. So the very first, I think we all use it very readily in our clinical practice, is your ABC scale, your activity-specific balance, balance confidence scale. This scale has an excellent retest reliability and also has good correlation with your functional gait assessment. You have the Morse fall scale, which has a good sensitivity but is not very well versed with its specificity. You have the St. Thomas risk assessment tool, that is this your Stratify scale, which has an excellent inter-rater validity. You have your FES, which is a highly recommended scale and has an excellent retest reliability. You have your John Hopkins fall risk assessment tool, which has a good sensitivity, but again, it does not have a good specificity. And you have your Austin Health Risk screening tool, which gives you a moderate inter-rater reliability. What we learn out of all these assessment tools that we just learned is, if you want to assess your predictors of fall, the primary tool that we all will be using remains your gait speed and your time up and go test. While if you want to assess an individual component per se, balance or gait, or cognition or any other, you will go for a particular specific case, say for example, work balance scale or mini best scale or DGI or MOCA. If you want to assess the self-reported measure, their own perception about their fall, we will usually go for FES scale, FES or short version of FES, and then or an activity-specific balance confidence scale. These scales, which I just mentioned right now, have good reliability, validity, good specificity, sensitivity, and have been proven in literature to assess either components of fall or fall individually very well.